So, what about the clinical presentation line, and is it clear-cut and straightforward? So, if it was clear-cut and straightforward, would any of you be here on a Tuesday evening? No. So, we kind of know the answer. You can break the diagnosis of Lyme. I look at it in kind of four categories. So, this is kind of my way of looking at it. You've had a tick, you don't know if it has Lyme's or not, so we'd call that post-exposure prophylaxis. You could call it early treatment, but you don't know what the person has. There's the acute presentation, which is what we consider typical for Lyme's, the late presentation. And then what I would call the post-treatment Lyme syndrome, which is, some people may call it chronic Lyme, but I think a lot of it is almost like the post-viral syndrome. So again, I like this just because it's colorful. It would be better on a big screen. But basically, you get the tick bite. Usually within a couple of weeks, you start developing your antibody. You'll get your erythema migrans, which typically is the bullseye, although about half the time you don't get the spot in the middle. It just becomes a red lesion. But if you don't get treatment at that time, or sometimes associated with that, you'll get neurologic symptoms. Sometimes it's sort of like a viral meningitis type presentation or Bell's palsy. So if someone presents Bell's palsy this time of year, has been outdoor hiking, think Lyme disease. That's something that I think we don't tend to think along those ways. Often people presenting will actually have systemic reaction. They won't get they'll get that, their big bullseye, but they'll also be feeling a little bit crappy. They'll feel a little, chills and fever, systemic. So it gives you an idea that it's more than just a little bug bite, for example. And then if you don't treat that, what you may find going out a little bit further out is people might get multiple red lesions. They may get more of a meningitis. They get the carditis, which is usually first-degree heart block, can be second-degree, and the arthritis, which is the hallmark. And keeping in mind that how Lyme disease was first described by Alan Steers, and he was a pediatric rheumatologist. And of course, it's called Lyme disease because he was working in Lyme, Connecticut. So in that area, there was a number of children over a couple of years who were basically presenting in the summertime with arthritis. And people couldn't figure out why this was happening. So he spoke to parents, figured it out, and that's how they developed the figuring that there obviously was some commonality. And then Bergdorfer was able to actually identify I think it was out of the fluid of the joint, actually found the spirochete, the Borrelia, that was associated with it, and this is how it all came. The reason why I find it interesting was Lyme disease, when first described, was a pediatric disease. And when we talk about regions where we don't have a lot of Lyme disease in Ontario, and we have these adults who haven't been outside very much but are convinced they have chronic Lyme, interestingly, most of the time these areas have not had a lot of pediatric Lyme. And, maybe kids don't play outside as much as they used to. But on the other hand, it's hard to imagine that we're going to have more adults having it and not seeing it among children. But just something else to sort of keep in mind. So if there has been a tick bite, and you are in a Lyme endemic area, the recommendation is give a single dose of antibiotics and you prevent Lyme disease. So it's 200 milligrams doxy, one-shot deal. And basically, if it's an endemic area, preferably there's a tick bite. Yeah, it's a black-legged tick. That would be helpful. They have to be on for at least more than 24 hours. Otherwise, you really don't need it, as I've already mentioned. And of course, the doxy is not a contraindication. So if a woman's pregnant, trying to get pregnant, childbearing age is a little bit broader, I think you want to be careful using a tetracycline. And so, in fact, we don't give this in kids under 8. And people say, well, can you use amoxicillin? There's absolutely no data to support amoxicillin after tick bite in children because no one studied it. Now, keeping in mind, if you actually look at that study in the New England Journal, the difference was about 8%. So what that meant was that the majority of people, if you're looking at the number of people who got Lyme versus the people who got the prophylaxis, like it was like 2 out of 100 versus like 8 out of 100. So that means that the vast majority of people who had tick bites didn't develop Lyme disease. So you have to keep that in mind, that you're still talking about relatively small numbers. And even if you give the antibiotic, you have to tell people, well, see what happens over the next month. If you have symptoms, remember you had a tick bite. Or you don't give the antibiotic and you say, well, if you get symptoms, come back and I'll treat you then. And that's completely legitimate. So just a couple of cases that I saw in Eastern Ontario. One was a fellow who every fall goes hunting with his son, and they go in this large meadow, and I'm not sure what they're shooting at, but basically a couple of days later he develops flu-like illness, fibromyalgia. He has a small red patch on his leg. And I saw him on day 5. He had no other physical symptoms, so I treated him with doxycycline. It was, although this was certainly past 3 days for prophylaxis early on. I gave him a 2-week course of antibiotics. In retrospect, was that the wrong thing to do? Because I know a little bit more now than I did back then. Hard to say because he didn't fit into any classic category. I asked him, he didn't read the textbook or our handouts. And of course his serology was negative. At the time I hadn't thought about this, because he already had some systemic illness, I would have expected. But for the course of disease, if you treat the Lyme early enough, your serology testing will be negative. You're not going to mount an IgM or an IgG response. And so here's the kind of case that I think this guy had Lyme disease. And based on what we want to do, I should be reporting him as a suspected case of Lyme. But because he was treated early, certainly within less than a week, he did not have a serologic response. Now, I could also be wrong. I can't be proven one way or the other. But if we're going to treat Lyme's early, this is exactly what we're going to be having. And that's what makes the diagnosis difficult, is if we treat early, we're not going to have the proof of it.
When does the serology change?
It takes IgM, usually more than a week, usually about 2 weeks for IgG. And once you get the IgG response, you're always going to be positive, which is why you have some of these people who would treat and say, well, I still have chronic Lyme disease, and their serology is positive. They say, I told you I have Lyme disease, not recognizing that the serology, which is an antibody response, remains positive. It may wane over time, but if you're going to do a Western blot, you're going to get a reaction. So this is where the problem with serology and the diagnostic accuracy is not helpful. It's not helpful very early. It's not helpful very late. It's only helpful late because if it's negative, that person didn't have Lyme. But if it's negative early, it's not helpful. Second case, which is one of the first ones I saw, and this is going back more than about 15 years now, was a fellow who spends about a month every year down in Martha's Vineyard. And of course, that's a known Lyme area for many years. And he had a border collie, and the dog would go out. And what he would do at night, he'd bring the dog back in, and he'd sit the dog down, and he was picking ticks off the dog. And he came back early because he wasn't feeling well from his usual 4-week holiday. And he developed, basically, it was almost like a transverse myelitis. He basically had complete flaccid paralysis from T12 down. Had some sensation, no movement whatsoever. He did not recall any tick bites, but we figured that history was reasonable enough. We treated him with IV ceftriaxone as a neurolymes. Serology was very positive, like massively elevated. He had some neurologic recovery after 7 days of treatment. We treated him for 4 weeks, and within 4 weeks, all his symptoms recovered, and he was back walking. So it was a kind of a good news story. But just trying to give you the contrast of one guy comes in early, we get nothing. This guy, high serology, and this guy, we were really concerned he was not going to recover at all. These are the common clinical symptoms. 70% get the erythema migrans, but it's not 100%. Now, whether that's because some people get a tick bite and it's in an area that they may not readily see, and maybe they get a local reaction and it's not detected, I don't know. Because, hey, if it's not detected, how do you know? Fundamentally. Arthritis in about a third of patients. And, of course, that being the hallmark sign in kids, it's just interesting to realize there are probably a lot of other kids who had Lyme disease back then and probably never had symptoms. Bell's palsy, 1 in 10. The radiculopathy is less. And the carditis, which is considered the hallmark, is actually really, really unusual. So in a region like this, like say you do have 6 cases a year, I mean, that'll take you, the likelihood is maybe you're going to see 1 case of carditis every 16 years in this region. So that's going to be relatively unlikely. Or if you see one, it's like, don't buy lottery tickets because your numbers just came in. And I mean, even the erythema migrans, which is common, it's hard in this picture, but if we're going to circulate these slides, you can see there's all different ways it presents, so it's not typically typical in that sense. And like here it says only 20% have the bullseye. Other people say it's 40%. So again, I don't know what to tell you. Everywhere you read, you'll get slightly different statistics. I mean, I look at that one on at the bottom here, and that looks like it's red and raised. To me, that looks like a bee bite, but whatever. And the differential diagnosis, of course, anything from ringworm, syphilis like this, I think would be unlikely. But if you had sort of a red patch, cellulitis certainly. But the thing with these patches is they're usually non-tender, and I've never seen a cellulitis that's non-tender. Insect bites tend to be itchier, tick bites are not. So those are some of the things that might help differentiate to some degree. I've sort of talked about this before, but this is the early disseminated stage, such as the facial palsies, and some of the other joint involvement. And like I say here about the testing in this stage is virtually always positive. So it's useful, although most people would say, well, you're not going to wait for serology with the right history. You're probably going to start therapy. But if you're not really certain, you might wait to get the testing. And here, I want to point out the last point there. So if you saw the patient earlier and the serology was negative, and within that 1 to 2 weeks, you may want to repeat the serology because it may be converting. I mean, that's how we treat things clinically, anyways, right? You have an index of suspicion, patient's at risk. The first test negative, you might repeat it. The neuro-Lymes 10 to 15%, again, so we see a lot. So, again, you're talking about July to October where you're getting some of the meningitis symptoms, but that's also when we get viral meningitis. We tend to get a lot of enteroviral meningitis, usually August and September. So there's a bit of an overlap. I guess a person comes in like that, doing an LP would be somewhat appropriate, but, that's not going to be the answer. I guess if you had a very low lymphocytosis, would that be enough to say, okay, it's likely not a viral meningitis, so we're going to give antibiotics? I'd have to be convinced that the risk factors were high enough in what the patient was doing to actually consider that. So to me, that's a bit of a gray zone that I haven't really explored, just based on the time of year and sort of mapping when they've actually been outdoors, when they may have been bitten by a tick or not, and weighing that based on your diagnostic criteria. In this case, you may have to get the serology in to make that diagnosis. Otherwise, you're committing basically to, probably at least 2 weeks of IV therapy. And you may start that. Well, we often do that with meningitis. We start anyways, but trying to get that test within 48 hours would be helpful if at all possible, because then you can probably stop the antibiotics if it's not Lyme. So if we don't treat it early, then you get the late dissemination disease, which, as I mentioned, is the arthritis. And again, this is where it starts getting complicated because it's usually knees and elbows, painful, swollen. Occasionally people have been able to do PCR fluid and identify Lyme. That's not a routine test. I don't know, honestly, if our lab does that. Probably have to call and see that. But what I find interesting here is that a lot of these people who present actually don't recall being bitten by a tick. So again, from a diagnostic standpoint, patient doesn't recall being bitten by a tick, has this, how do you, someone comes in with a monoarthritis and inflammation, I'm thinking gonorrhea before I'm thinking Lyme disease. So, let's be honest, it's complicated. But in these cases, they are 100% going to have an IgG response, because this is all you're getting out about 4 weeks, and if their IgG is negative for Lyme, they don't have Lyme.
How easy is it to culture the Borrelia out of an active joint? Should we be doing that if there's something that we looked at gonorrhea? Should we ask that?
Well, I don't think you can really culture the Borrelia.
You can't. Okay.
Yeah. I mean, it has been grown, but it's very, very specialized. It has been seen occasionally if it's a massive infection, so people have seen it microscopically, but that's pretty unusual, so that's why PCR would be the more reliable.
For record, for instance, if you're not at the Rocky Mountain Microbiology Laboratory, where Willie's desk is still there,
Yeah.
you cannot go.
Okay. Fair.
Yeah.
Thanks.
Then there's the European Lymes. The difference here is that you don't tend to have the arthritis with the European Lymes. So where you'll see is, people who have gone to, I have to do this for Vicky, people have gone to Poland, Yeah, not skiing because it's not ski season. Vicky went skiing in Poland. We tease her because she flew there via Zurich, and we don't know why she didn't ski the Alps. But that's a different story entirely. That's for over pizza. But if you have a patient who's been over in Europe, maybe they've been hiking the Tyroleans, and maybe they're bitten by a tick, and you can see the numbers from Austria that I mentioned before, which are 4 times that of the U.S. And you're going to send serology. Notify the lab that there may have been exposure in Europe because they will interpret the testing somewhat differently. Because they're not the exact organisms, the bandings will look somewhat different. There's also this different type of I had never heard of this until we got prepared. Acrodermatitis chronica atropicans. Basically, they have funny looking skin, which is one of the chronic, and there's a picture there of the foot, and that was associated with Lyme disease. So again, similar kind of presentation, different ticks, different Borrelia, and they tend to similarly they'll get the target lesions, so they'll get the erythema migrans, they get neuro, and then they get chronic skin conditions. They do not get the arthritis, and I've never seen a case, and neither have any of my colleagues. So we're telling you from the books.
Yeah, but the dermatologic literature for the sclerosing skin conditions often don't separate the European from the North American conditions.
Interesting.
And so that it's confusing to people. Because scleroderma and morphea are relatively common.
Yeah.
But people are now chasing Lyme's disease and all of these things because the Central European literature is contaminated the North American literature.
Well, because let's face it, you Google and you'll get whatever's come up and what people search. I mean, you're quite right. But I just wanted to sort of point out it's not the same. You do have to flag it on your requisition, because if you don't, we're going to miss it.
And is there any diagnostics for that skin condition? Because that was the first patient that I got. She brought me that, all the information of the acrodermatitis.
Again, because it's a later disease, the serology will be positive.
Okay.
Treatment, preferred treatment of choice. I mean, basically, it's a spirochete, penicillin, erythromycin, and tetracyclines all work. The doxycycline is the most convenient. Why we give 100 milligrams twice a day rather than 200 milligrams once a day for a drug that has a half-life of 7 hours or something like that. It's just the way it happens. It's fine. Amoxil works, just less convenient. Penicillin certainly was effective in the early days. People kind of got away from using it just because penicillin is less convenient. But of course, amoxil is just easier than using Pen-G. Erythromycin, as you know, back when it was tested, was inferior to the other two. That's why you don't see it there. I presume, and if you had a penicillin allergy in someone who you couldn't give doxycycline to, that would be your third choice, but you don't find it in the standard recommendations. Again, treatment length for the acute is basically 14 days. I think 10 to 14 days. There is this controversy saying we should be treating longer. I have no idea why. But of course, if you do have some of the other complications like cardiac or neurologic, you're going to treat longer. It's not that there's been a lot of randomized studies of longer. It's just that those have tended to be the diseases that we tend to treat longer. So we treat them longer. I actually don't know if there's a higher failure rate. But if you're treating an arthritis, just like it was a septic arthritis, we would usually go longer. So if it's bacterial, we'd probably go closer to 6 weeks. So that's where we're doing that. For the late presentation, again, we tend to go longer, and part of that is, as I mentioned, whether it's because there's a failure of a shorter course of therapy or because it's now established. So the recommendation now is go for 4 weeks, and if that doesn't relieve it, as I mentioned before, go for anti-inflammatory agents. And this is in the slides. You can look at it. Pen-G is down on the bottom there, and under alternative therapies, macrolides are listed as well. And so this is part of the IDSA guidelines. What's interesting as well is these IDSA guidelines now are, was this 2008? Something like that. So they should have been updated. So what's interesting is very little has changed in the guidelines, but Most guideline trackers only, like if you're looking for systematic reviews, only look at guidelines for the last 5 years. So when people do the tracking for guidelines, they actually don't, from that guideline tracker, they don't pick up these guidelines because they're more than 5 years old. Of course, with the delay of the release of the new guidelines, you now have a bit of a problem. So the latest guidelines are the ones that have come up by the International Society of Lyme Disease. That's the other side of the coin.